Welcome. We're going to get started in just a moment. Given that this is Zoom, we want to make sure that everyone has the opportunity to join us this evening. So we will get started in just a minute or two. Thanks for being with us. All right. Good evening, everyone, and thanks for joining our Men's Health webinar. We're so excited to have the opportunity to share important men's health education with this group tonight. My name is Brittany Conan, and I am the host of tonight's event. I'll start with a couple housekeeping items, and then I'll introduce our speaker. Most importantly, your participation is completely anonymous to other attendees. No one can see your face or your name, and any questions that you ask can only be seen by myself and the speaker. We encourage interactive presentations, so if you'd like to ask a question, please type it in the chat box at the lower part of your screen, and we'll save time at the end of the presentation to answer as many as we can. Tonight's webinar will be presented by Dr. Redger, a prosthetic urologist and men's health specialist at the University of Kansas. Dr. Redger, I know your time is in high demand, and I thank you for your willingness to be with us this evening to share important education with this community. I'll turn it over to you.
All right, thank you so much, Brittany. I appreciate it. So thanks everybody for joining us. Before we get started, I want to let you know just a little bit about me. I'm actually a Southwest Kansas kid. I grew up in a town called Montezuma in the middle of nowhere. No stoplights, 900 people, 23 kids in my graduating class from high school. So grew up on a farm in nowhere, and I'm happy to still be in Kansas today. I went to undergrad at Creighton University in Omaha, Nebraska, medical school at KU. And then I did residency at Stony Brook and did a 2-year fellowship with Dr. Brian Flynn at the University of Colorado in both reconstruction and men's health. So I've been in practice for several years now at KU. I do a lot of these treatments for erectile dysfunction and stress urinary incontinence. So I'm excited to talk to you a little bit about options out there. So first, we want to talk about what is erectile dysfunction. So that is kind of defined as the ability to achieve or maintain an erection that is firm enough to complete a sexual intercourse activity. And it's very common. People like to talk about it a lot, but about 1 in 5 American men will get ET at least at some point in their lifetime. And more than half of the men over the age of 40 will develop some form of degree or some amount of ED. The way it works is typically when you have the desire to have sex, the nerves around the penis become activated. And that allows the muscles inside the penile tissue to relax. That increases blood flow into the penis. Once the blood flow increases, you have some erectile tissue that engorges, and then it compresses on the veins that live on the outside so that the veins can't drain. So you essentially have inflow of blood without outflow, and that allows an erection to occur. When people develop erectile dysfunction, there's usually a problem that affects the anatomy, okay? One of the most common causes are vascular disorders, diabetes mellitus, and medication side effects. Commonly medications for high blood pressure treatments or medications for depression, things of that nature. Erectile dysfunction can also be a result of treatments for prostate cancer, such as radiation therapy or removing the prostate surgically. When you get erectile dysfunction, sometimes that can be a presenting symptom for diseases like diabetes, heart disease, and vascular diseases. And erectile dysfunction can cause people to lose a little confidence and affect and impact their quality of life. So it's erectile dysfunction and diabetes have a very close connection. And as time goes by, more and more people are getting diabetes. About 15 million people in the United States have had diabetes, according to the 2015 census. People with diabetes are usually less responsive to oral treatments, such as the blue pill that you see on TV all the time. And men with ED and diabetes can be more severe, and they can have a higher increase or higher decrease in quality of life. The reason that diabetes can worsen erectile dysfunction is that diabetes can affect the nerves and cause damage. You've heard a lot of people get neuropathy in their feet. The same thing can happen to the nerves of the penis. They can also get burnt out. Diabetes also accelerates damage to the inner lining of the small arteries. So the further away you get from the middle of the body, where there's this big vessel called the aorta that provides blood flow to the different parts of the body, the smaller the vessels get. And the smaller the vessels get, the easier they can become damaged from something like diabetes and have a hard time bringing blood to the organs that they serve. So erectile dysfunction pills require stimulation of the nerves, which can be damaged with diabetes, and also help, and they also require there to be healthy blood vessels to bring blood into the penis, which also gets damaged with diabetes. Other factors that increase erectile dysfunction are advancing age. So the older you get, the more likely you are to get ED. The longer you've had diabetes, the more likely you can have injury to the nerves or the blood vessels. If you have a poor glycemic control and high blood sugars, that can make erectile dysfunction worse. If you have vascular disease or heart disease, those can all increase your chance of getting erectile dysfunction. There is also a link between erectile dysfunction and heart disease. In med school, we're always taught that erectile dysfunction can be like a canary in a coal mine, and it can precede a diagnosis of coronary artery disease by 2 to 3 years. And erectile dysfunction has been shown to be an independent risk factor for future heart-related events, including a heart attack. The reason that erectile dysfunction happens first before you get diagnosed with some other conditions are that the arteries supplying the penis, like we talked about earlier, are much smaller than those of the heart. And so when those become blocked, up to 50% obstructed, then the penile artery can cause symptoms, or when it can't bring blood to the penis, you're going to have symptoms of erectile dysfunction. So how can you reduce the risk of developing erectile dysfunction? There are a bunch of things you can do. You can make healthier lifestyle choices. I don't really like to use the word diet. I consider that nutrition. When you hear the word diet, you think that's temporary, like you're going to just go on a diet and then come off of a diet. But I feel like you should more consider this to be nutritional changes that are long-lasting and can vary that from day to day. Exercise and physical activity are very important. Resistance training, walking, it doesn't have to be anything crazy, but as long as you're doing regular exercise, that can help improve your overall health and erectile function. If you're overweight and you lose weight, that will be beneficial. If you stop smoking, it'll make your blood vessels less brittle and also help with erections. And if you can manage your stress, that will improve your anxiety-related erectile dysfunction. There's also some associations between low testosterone and erectile dysfunction. Low testosterone occurs when a man's body produces less testosterone than the normal population. And it's more common with obesity, partially because there's a special enzyme that lives in fat cells that converts testosterone into estrogen. So people that have more fat cells commonly will have less testosterone and more estrogen. It's common with diabetes, high blood pressure, high cholesterol, things that a lot of Americans and other people have. It's also common with prostate disease and asthma. So approximately 40% of men over the age of 45 can have low T. That doesn't always mean you're going to have symptoms of low testosterone like weakness, fatigue, low libido, things of that nature, but your testosterone can drop lower than normal. And for every 10-year increase in age, so the older you get, the higher the risk of low testosterone. There are treatment options if you are diagnosed with low testosterone. Usually, if we found that you had a low testosterone, we check it in the early morning, we'd recheck it, make sure it's still low, and then we can offer you therapies for that. To replace testosterone, you can use gels, there are patches, injections, oral medicines, and even some implants you can inject underneath the skin to deliver testosterone back into your body. And each of these options can kind of carry different peaks and valleys of how the medication is released. And they all have a different kind of side effect profiles that we could talk to you about. Erectile dysfunction is also quite common with prostate cancer treatment, and prostate cancer is quite common in men. Reason being that the nerves and some of the blood vessels that supply blood to the penis that allow for erections live very close to the prostate. The nerves actually kind of hug the outer capsule of the prostate. When you treat prostate cancer with either surgery or radiation therapy, it can damage those nerves and damage the blood vessels supplied to the penis as well. Sexual dysfunction is quite common after surgery for prostate cancer. It can infect up to 75% of men initially. And even when we do procedures to kind of peel those nerve bundles off of the capsule of the prostate to try to spare them, there can still be some issues with erectile dysfunction up to a year or more afterward. If men don't choose surgery to treat prostate cancer and instead do radiation therapy, the radiation can also damage the nerves and cause erectile dysfunction in up to 50% of men. There's another phenomenon called Peyronie's disease, where you can develop a scar tissue on the connective tissue sheath that surrounds the erectile bodies of the penis. When the scar tissue affects the sheath, the penis tries to become erect, it will bend toward the side of the scar because that part of the sheath can't expand like the rest of the penis. You can get a curve. Sometimes the curves are pretty minor, just a little bit, you would never even really notice. Other times they can be very severe. I've seen them go curve all the way back to the abdomen. I've seen S-shaped hourglass curves, you name it, I've seen it. When that happens, that can make it difficult to have sexual intercourse because the curve can be too severe, or it causes erectile dysfunction. The penis might not get as hard after the curve, or it can cause an instability of the penis, or has a hard time penetrating because it feels like it tries to bend. So a lot of things can happen with Peyronie's disease. It can also cause the man who has it anxiety or stress about how it looks, and they can be embarrassed to show it to their partner. So there are different treatment options for this curve. One could be a traction device, where you just kind of put your penis and kind of looks like a little duckbill. You can pull it on stretch and bend it against the curve. It's kind of like physical therapy for the curve of the scar tissue in the penis. You can do Xiaflex, which is injection therapy to help straighten out the penis. Or there's surgeries like plications or grafting procedures that are outpatient 1-hour surgeries or so. You can straighten out the penis. If people have curvature of the penis and erectile dysfunction, both, then something like a penile prosthesis, which we'll discuss later, is an excellent option to fix both of those things. Other treatments for Peyronie's disease, such as shockwave therapy, stem cell therapy, or platelet-rich plasma therapy, are all investigational. Shockwave, we typically use that if people have pain with erections, but that doesn't really improve the curvature. For erectile dysfunction, I'm sure many of you on this call have heard of oral medications such as Viagra or Cialis, because they're advertised quite frequently, the blue pill. That's usually the first thing we start with. It's the most common. If those don't work, or you can't take the pill, for example, you take nitrate medications and it's not safe, there are other therapies available, such as injection therapy, where you use a very small needle and inject some medicine directly into the penis. There's vacuum erection devices, which are all available on the market. You can kind of pick what you want, which kind of pull blood into the penis rather than your body pushing blood into the penis. There's a medication you can put inside the urethra to help with erections, and also penile implants, as we'll discuss a little bit later. With the oral medications, they work because they increase the amount of nitric oxide that hangs around the blood near the penis. And that nitric oxide allows more blood flow to go into the penis, so you increase your inflow. They're usually pretty effective and can work in up to 80% of cases. But some of the medications you commonly heard of, like Viagra, are not very fat soluble. So you need to take them on an empty stomach. If you eat a full meal and take a pill afterwards, you might not get any medicine in your bloodstream. They can have some side effects, including headache, flushing, upset stomach, sometimes a red-green color change, things of that nature. And if you have taken medications like an alpha blocker, or you've taken nitrate medications because you've had a history of heart attack, sometimes you can have some unsafe low blood pressure if you take those medications in combination with pills, and that can be dangerous. So you'd want to talk to your doctor before you try the pills. And almost half of men with ED who try oral medications usually give up if they stop working. And as we discussed earlier, men that have diabetes are up to 2 times more likely to move on to other treatments because the pills don't work as well. For injection therapy, we would teach you how to do this in the clinic. You can inject medication directly into the side of the penis, and the medication bypasses going through the liver or the kidney or anything like that. And so the medication goes directly into the penis and doesn't have to go through the rest of your body. It's a little bit more effective than pills at times, and approximately 40% of men can discontinue the therapy. Either they think there's burning at the injection site, it's painful, sometimes the erections last longer than they want to. And typically, if they quit it within 6 months. Most common side effects for injection therapy is penile pain, erections that last too long, so you'd have to be careful with the dose. If you have an erection more than 4 hours, you need to go to the emergency room to get that taken down. If not, if you have erections too long, it can permanently damage the erectile function of the penis. You may never be able to get erections again. It can also cause scar tissue and some swelling or bleeding underneath the skin at the site you inject. And a large number of studies have shown that patients will withdraw from this just because of those issues we mentioned. A vacuum erection device, you don't need a prescription for those. It's something, there's a whole bunch of places that sell them, including Amazon. It's basically a pump that creates a vacuum, like we talked about, where the pump pulls blood into the penis rather than your body pushing blood in. Then you have to wear a little band around the base of the penis to keep the blood in place. It's usually pretty effective. Satisfaction rates can range up to 80%. But in my anecdotal practice, I don't see too many people using them more than 2 years because it can be a little cumbersome. You have to be like, all right, hold that thought. I got to take care of some things. And then after they take care of it, you go back out and get what needs to be done. Sometimes the ring you have to put around the base of the penis, it can be a little bit hard to figure out. You don't want it too tight where it hurts, or you don't want it too loose where you lose the erection. So it has a little bit of a learning curve. But it can help increase some length in men that have lost length after prostatectomy or that had scar tissue in the penis. In one study, 86% of radical prostatectomy patients for prostate cancer that have tried vacuum erection devices moved on to other things. So not super common in all populations. A urethral suppository works by putting a little bit of medication into the urethral tube itself, which is the tube that you pee from. It's not quite as successful as the other therapies, up to 66% success rate. It can cause some pain or discomfort in the urethra, a little bleeding, a little spotting. And a lot of people discontinue this medication because it doesn't work as well. And they've had actually a pain and burning in the urethra. So they switch to other things. A penile implant is kind of the end all for if you have erectile dysfunction, other things don't work. The way it works is you have some natural cylinders in the penis that contain the erectile tissue that stops working over time. So we've replaced that natural erectile tissue with some silicone cylinders, as you can see here in the diagram. And those silicone cylinders are measured to size. And we give you the absolute longest one that we can. We measure the size of the penis, give you the longest implant possible. The second component of the implant is a little pump that lives in the scrotum. Everything's underneath the skin. You can't see anything outside the skin. And the third component is a little reservoir that lives by the bladder that holds fluid. So the penis can have a soft phase and an erect phase. The most common side effects for the penile implants are postoperative pain and swelling, infection, which is quite uncommon, thankfully, and mechanical malfunction over time requiring a revision surgery where we have to just swap out some old parts for some new parts. It's been shown that at 7 years, up to 9 out of 10 of these implants are still working, which is good. I've seen some go as long as 20, some fail as quick as 5. With penile implants, there are multiple types. There's a 3-piece device, which is the most common and has a higher satisfaction rate because it can have a flaccid and erect phase. It's just more natural. There's a 2-piece device and also a malleable implant. The malleable implants don't expand in length and girth like the others, but they will provide some rigidity. With the 3-piece penile implant, it's the most implanted, most common type that we do. And there's some companies that have a built-in antibiotic on the tissues themselves that help prevent infection when you implant this device. It's clinically proven to prevent infection. And this 3-piece device that we talked about mimics a natural erection compared to the other two. And it looks natural when it's deflated. These have been around since the 1970s, and more than 500,000 men have received them. This is how it works. A little video. So you can see inside the penis, there are cylinders that we measure to size. There's a pump in the scrotum that he's pumping to transfer fluid from this reservoir that lives by the bladder into the cylinders to provide rigidity. When intercourse is complete, there's a button that you press that transfers the fluid from the cylinders back into the reservoir to make the penis flaccid once more. Okay. This procedure is usually an outpatient procedure performed under a general anesthetic. And there's different approaches to place the implant. You can make a little opening on the scrotum right underneath the penis, or make a little opening right above the penis itself, kind of right by your pubic bone. And generally, after the surgery, you can be beat up for a little bit. You can have some swelling and some bruising, but you can return to light activity fairly quickly. And within 4 to 6 weeks, we give you a chance for all that swelling and bruising to go away. You come to see us in clinic, and we teach you how to cycle the implant, how to use it. It is common for insurance to cover this, especially if sometimes you have to try other things first. But if those things fail or don't work, then insurance will kind of pick up the bill for this implant. Usually it's commonly covered under Medicare and Medicaid and other things as well. There's also a little portal that we use to help make sure your insurance can help you afford this treatment. These are some men that have previously had the implants. You can see the guy on the left, John. He had diabetes and high blood pressure, and he's had an implant for 14 years. Cliff on the right had prostate cancer treatment and also has a 3-piece implant. And both of them had positive things to say. Said recovery wasn't too bad, and the implant has been really great. I got my life back. You hear a lot of guys say that, I got my life back. And when they get these implants, a lot of times sexual intercourse is something that people use to communicate with their spouses. It's a love language, and so people feel closer when they can get that activity back again. The benefits of the implants, they have a 97% patient satisfaction rate and 98% partner satisfaction rate with the 3-piece implant. They typically can be affordable when insurance covers them, and they're long-lasting. So they're permanent solutions. You don't need to worry about failure like you do with pills or injections. Once it's in, you're going to be able to get hard. They're very durable. About 9 out of 10 are still in use after 10 years. And again, they're natural. They're designed to appear natural, have a flaccid state and erect state, and make sex feel more spontaneous. There are risks involved with surgery. Some of the risks include that you might have failure of the implant. That could be due to a leaking of fluid or over time or something of that nature. If that happens, you wouldn't be able to cycle the implant, meaning make it inflate or deflate, and that would require a procedure to kind of swap out some old parts for new parts. It can be relatively painful, especially in the healing process, and you can have a lot of bruising and swelling during the healing process. Men with diabetes, spinal cord injuries, open sores, if men have take immunosuppressive medications for like rheumatoid arthritis or Crohn's disease, something of that nature, they're all a little high risk of infection. But the general population has about a 1 or 2% risk that these become infected. If you have diabetes and your A1C is above 8, kind of jumps to 3 or 4%, and the higher the A1C is, the higher the rate of infection. So generally, when you have diabetes, we make sure that your A1C is at 8% or below. So in summary, ED is very common. There are a variety of treatment options, and penile implants are a solution that's long-lasting and satisfactory if other things fail. Now we're going to move on to talking about stress incontinence in men. So stress urinary incontinence is known as bladder leakage. When a person can't stop leakage, when he coughs, sneezes, laughs, moves, basically any activity-related thing can make you leak urine. It's relatively common. 500,000 men can suffer from this condition, and nearly 1 in 20 men over the age of 20 years have moderate to severe incontinence of either stress or urge. The way a normal urinary system works is the bladder stores urine that's produced from the kidneys. When the bladder becomes full, the sphincters that help hold the urine in, there's a sphincter at the bladder neck and a sphincter on the other side of the prostate, pop open. When those sphincters pop open, the bladder muscle itself squeezes and allows urine to exit the urethral tube and out the penis. When these sphincters are contracting, their job is to keep the urine into the bladder. And when they relax, like I said, the urine exits. Stress urinary incontinence in men is most strongly correlated with prostate cancer surgery and prostate cancer treatment in general, including radiation. Up to 50% of men report leakage immediately after surgery for prostate cancer. So oftentimes we leave a catheter in the bladder after the prostate has been removed because you have to reconnect the bladder to the urethral tube. Once the catheter comes out, there's usually only one sphincter left, not two. So men have to learn to use just the one sphincter. So commonly, they'll have erectile dysfunction for even up to a year after treatment. And up to 16% of men will have incontinence after 1 year that persists. Incontinence can also be a result of neurologic disorders or injuries, like a spinal cord injury. After prostate surgery, not for cancer, but for large prostate, like a holmium laser enucleation or a TURP or something like that. It can happen after radiation therapy or pelvic trauma. If someone's had a car accident and fractured their pelvis, that can also damage the integrity of the urethra and cause leakage at times. So stress urinary incontinence can really affect the quality of life in men. Men that have stress incontinence can be more depressed, they're distressed, and they feel socially isolated. Sometimes they feel like they can't leave the house because they don't want to smell like urine. They feel like they have to change diapers all day or pads, and they just feel like that's all they're doing all day is changing that. It can be very stressful. So stress urinary incontinence and prostate cancer treatment is commonly connected. There are approximately 70,000 radical prostatectomies performed each year. And like we mentioned earlier, approximately up to 16% of men can have persistent incontinence after surgery 1 year after treatment. And part of that's the same reason, because the nerves and blood vessels can be affected. If you have a very short posterior urethral stump, so if you have a very short connection between the bladder and the urethra, sometimes the bladder has to be connected very close to the last sphincter that's remaining. It's right here. You can kind of pull that sphincter open a little bit when the bladder fills. And that can make men leak a little bit with a full bladder. There are short-term options to try to help with this incontinence. From a behavioral standpoint, you can reduce your fluid intake and also not wait too long between voiding. So don't try to wait 3 or 4 hours between urinating because patients with fuller bladders can have have more leakage. So if you go every 1 or 2 hours, that can help decrease the volume that you leak. Pelvic floor physical therapy is something we recommend all of our patients to do. They can teach you Kegel exercises, biofeedback techniques to help strengthen that pelvic floor and hold the urine in with that single sphincter you have remaining. To help prevent soiling clothes or anything like that, or sheets overnight, there are pads, diapers, condom catheters or other kind of catheters or penile clamps that can be used to help decrease the amount of leakage present. The coping solutions such as the pads and the catheters can be kind of a nuisance. They can be expensive, depending on how many you have to use. Some people I've seen go through 15 diapers a day or more. The products can be bulky and hard to carry in a purse or a bag. They can smell. Catheters can be uncomfortable if you use those. And a penile clamp, they control the leakage. You can't wear it 24/7 because you want to have some blood flow to the penis at some point during the day. So that can cause some sores and discomfort and pain on the penis as well. If you do 5 pads a day for 5 years, that can amount up to $7,000. So it's very expensive, probably more these days. So there's several long-term solutions for stress incontinence if that persists after you've tried physical therapy and other things. One is a male sling. It's undetectable, nobody can see it, and it has high success rates in people that have mild to moderate incontinence. And I don't use it commonly in radiated patients either. If it's a radiated patient, it has to be used in somebody that has just very minimal radiation changes. Most patients are continent immediately after the procedure, which is one of the benefits of a male sling. Basically, you go to sleep and you were wet when you went to sleep and you wake up and you should be much drier, if not all the way dry. You don't have to use your hands. It's not mechanical. It's basically kind of a set it and forget it and you're done. At least 9 out of 10 men that undergo the procedure would do it again. The male sling kind of acts as a hammock. You can see in this diagram here, where it kind of cushions on the urethra, and it's kind of anchored kind of near your pubic bone. And it kind of supports the urethra when you cough, sneeze, laugh, and move to help you hold urine in. Like we mentioned, up to 94% of people that received a sling would recommend the procedure to a friend. Another option is the artificial urinary sphincter. This is considered a gold standard treatment, also been around since the 1970s. It helps improve quality of life because it can be used in men that have a very high volume, moderate to high volume incontinence, men with radiation therapy, men that have more severe issues. The way it works is it mimics a healthy sphincter because it has a 360-degree balloon that goes all the way around the urethra and keeps the urethra compressed and closed at all times until you press a button to open up that sphincter and allow you to urinate for about 1.5 to 2 minutes. The way it works, as we mentioned, there are 3 pieces, just kind of like the 3-piece penile prosthesis. There's a cuff that goes around the urethra, a pump that lives in the scrotum, and a 23-milliliter balloon that lives by the bladder that has a certain pressure in it. So that the pressure in the balloon helps keep pressure in this cuff, and the cuff squeezes around the urethral tube until you press this pump to allow that cuff to pop open for a little bit. And then once you're done urinating, the cuff closes itself, so it doesn't need to be closed by the patient. This is a video on how it works. Again, if a patient presses this pump, you'll see the cuff opens. And then slowly this pressure rating balloon pushes the fluid back into the cuff to close it. So just like the inflatable penile prosthesis, this is also an outpatient procedure. Usually there are 2 incisions, one incision between the scrotum and the rectum to where we can locate that very healthy, juicy part of the urethra to put the cuff around. And there's usually another incision above the pubic bone on either the right or left side, where we make connections between all 3 of the pieces that we showed in that diagram and put that little pressure regulating balloon by the bladder. Again, you're going to be a tender for a few days. You can return to non-light activities, walking, things of that nature. And we wait 4 to 6 weeks before we activate the implant. The reason we do that, the pump in the scrotum can be very tender. So it'd be kind of cruel to have somebody try to find that pump in a swollen scrotum and press that every 3 or 4 hours when they have to urinate. So we leave the cuff open and deactivate it until you see us in clinic. Patients are usually very satisfied with this therapy. Up to 95% of patients were satisfied with it. And even in 9 out of 10 were satisfied long-term. Up to 90% of patients, 9 out of 10 would have the surgery again. And again, 9 out of 10 patients recommend this procedure to a friend as well. Just like the inflatable penile prosthesis, insurance can cover it. And a lot of times, if this comes after prostate cancer treatment, it's very common that it's covered. And so don't let that be a barrier. And we have a financial team in place that can help work with the insurance company and make sure this is an option for you. So same as before, Herschel and Fabio, both patients had prostate cancer treatments and received sphincters. This patient went from 9 pads a day to 1, and he just used that 1 safety pad if he laughs really hard, and he says it makes me feel like I can do things I want to do with the confidence of not having to worry if I wet it myself. Fabio said recovery is very easy. Took me about 1.5 weeks where I was walking around without any pain. I walked the first week, no scarring. No one can tell it's there. So these stress urinary incontinence products like the sling or the artificial sphincter can help patients achieve continence again and urinate when they want to, not just feel it run down the leg or into the diaper. It's entirely inside the body, both of the products, so you'll never see them or know they're there. Very high patient satisfaction rates. They can help restore normalcy and confidence in patients' lives. There are risks with this procedure, just like anything else. With a male sling, there's a chance, especially in patients that if they've had radiation therapy, that you can't get it quite tight enough to get everybody all the way dry. So they can still have some incontinence when they wake up. Sometimes the opposite happens and the sling is too tight and can cause retention of urine where a patient can't pee without the help of a catheter. If that happens for more than 6 weeks, sometimes we have to do a second procedure to kind of loosen that sling a little bit. There can be some postoperative pain and even chronic pain in the groins from where we have to set that sling. There can be irritation at the wound site, wound complications, and over time, 5, 6 years plus, sometimes you can have some recurrent incontinence over time. For the artificial sphincter, just like the inflatable prosthesis, it's a mechanical device. So you can have mechanical failure where you have a leak of fluid or the button doesn't work or something happens to where the device doesn't work anymore. If the cuff has been around the urethra for a long time, sometimes that urethra can shrink a little bit and it gets skinnier and the device won't work as well. You can have erosion of the artificial sphincter cuff to where it can go through the urethra and show itself to the urine. That ever happen, that requires removal of the cuff and then repair of the urethra and replacement at a later date. And just like the inflatable prosthesis, you can also have a infection with these, although it's also very low. So in summary, stress incontinence is a known side effect of prostate cancer treatments. There's a variety of options available to help with stress incontinence. Short-term options can be expensive, such as the pads or the clamp or catheters. And a male sling or an AUS could offer a better long-term solution to improve your quality of life. Okay. Thank you.
Thank you, Dr. Redger. I loved hearing your presentation. This is the first time for me, so thank you so much for your expertise and walking through both slide decks there. Before we let you go, if anyone has a question that they'd like to ask, now is the time to do so in the chat feature at the bottom of your screen. One question that comes up a lot is age. With either disease state or treatment option, is age ever an obstacle when it comes to any of these treatment options?
Not necessarily.